Welcome to Open Classroom, the Brown School's digital forum for community and conversation. My name is Danny Pape, and I'm the Director of Career Services here at the Brown School at Washington University in St. Louis. Thank you for joining our program today, The Impacts of Expansion of Medicaid in Missouri Early Results, which is a part of our awesome curriculum showcase. Before we get started, I'd like to do some housekeeping with you so you have an idea of how we'll spend the next hour. First, we're using a Zoom webinar format, which means we can't see or hear you, but we can and do want to engage with you through the chat. So please open up your chat and we will have folks watching that throughout the hour. We're also streaming live now on YouTube. A link to that is will be put in the chat. However, we're not able to moderate the Q&A on YouTube. So if you're watching us that way, please know that we'll find ways to engage you. Today's program, The Impacts of Expansion of Medicaid in Missouri, is a part of our Curriculum Showcase series. Our next Curriculum Showcase is February 2nd, and we'll offer an introduction to epidemiology and causal inference. So we'll hope you'll join us for that. I'd also like to do one last highlight, which is our upcoming Black History Month Open Classroom series. The first program in that series is entitled COVID-19 Pandemic and the Impact on Our School Communities. And that'll take place tomorrow, January 25th. A link to our Open Classroom webpage will be popping up in the chat soon, so you can go and register if you'd like to attend. But now to today's program. So it's my honor to introduce Sarah Birch, the Associate Director of Admissions and Recruitment here at the Brown School, and she will get us started and introduce our awesome speaker. Go ahead, Sarah.
Great. Thank you, Danny, and welcome everyone. We're so glad to have you here today. I'd like to give a special welcome to those joining us today who are prospective students. We're really excited to be partnering with Open Classroom again this year to offer this curriculum showcase series in which we hope that you get the opportunity to get a little taste of what it's like to be in a classroom and among some of our really phenomenal and esteemed faculty members. And so I do have the pleasure of getting to introduce our speaker today, who is one of those esteemed faculty members, Timothy McBride. He is the Bernard Becker Professor here at the Brown School at Washington University in St. Louis. He also serves as the chair of the Health Policy Analysis Specialization for the Master of Public Health program. An influential health policy analyst and a leading health economist. His work shapes the national agenda in health insurance, health reform, rural health care, Medicare policy, and Medicaid policy, which is the topic of today's session. So without further ado, I will turn it over to my colleague, Tim.
Thanks so much, Sarah and Daniel and Sarah. And it's great to be here with all of you, community friends. I see a couple names I recognize, and prospective students. You can see my slides, right? Great. I'm here to talk about this topic of Medicaid expansion in Missouri, and I say after 1 year because I'll go over some of the background here in a minute, but we're about a year into the expansion in Missouri. We expanded in October of 2021. So at the end of October 22, we're about 1 year in. So I want to I'm going to give you some of the background about how we got here, and then talk about where we're at right now and some early numbers. We're still sorting this out as we speak. I titled this The Long and Winding Road. We're joking that I'm a Beatles fan, and so I've been doing Medicaid research probably when Medicaid expansion passed. I thought about the first time I wrote about this, and it was 2005. So that's about 16 years of work until Medicaid expansion passed. So I started to title my talks Long and Winding Road, one of my favorite Beatles songs. So now it's not working, or maybe it is working. There we go. So if you're a Beatles fan, you'll appreciate that. And okay, I'll stop that distraction. So just for the prospective students and others from outside of Missouri who may not know a little bit about my background and what I teach in the curriculum. Here's a little bit about me. I'm a health economist by training. I got my bachelor's degree and master's and PhD from Wisconsin, and then did take a long and winding road to Washington, D.C., and worked at a think tank there, and about 30 years ago moved to St. Louis. And I like to say I can't hold a job because I've been at all three universities in St. Louis. St. Louis University, University of Missouri, St. Louis, and for the last almost 15 years now, Washington University, where I joined the Brown School here. And as Sarah mentioned, I head up the health policy specialization. I also am co-director for our Center for Health Economics and Policy in the Institute for Public Health. And maybe of relevance to today's talk, I'm the former chair of the what's called the Mo Health Net Oversight Committee, which is oversight over Medicaid, which I chaired for 9 years. And so that was one of the places where I really started to get my feet wet, thinking about Medicaid policy. I've done a lot of work on Medicare policy. For the Brown School, if you decide to come, and I hope you do, for those of you who are prospective students, I teach health policy and health economics in general. So today I'm going to talk, about a particular policy topic, the expansion, which is a pretty interesting topic, especially in Missouri. I think we never do things simply in Missouri. It is complicated, as I'll explain to you, so I'll give you a little bit of history of its passage, some of the implementation challenges we've faced, and where we are now in potential impact of the expansion. And I want to acknowledge the funding source for most of this work is the Missouri Foundation for Health, which gave us a grant to study the implementation of the expansion, and also is now helping us study evaluate the expansion itself. So just a background on the vote that happened in Medicaid expansion. That vote happened in 2020, August 4th, 2020. The voters voted to expand Medicaid. We were the 39th state to vote to expand Medicaid, and the map shows you those states in light blue that have voted to expand Medicaid. The ones in dark blue have not. And what's notable, though, is Missouri was one of the states of about 7 now. We were the 6th to vote as a ballot initiative to vote to expand Medicaid. And so that's notable. After the first, say, 30 some states passed expansion through sort of the legislative process, most of the other states could not get it through the legislative process, and they turned to the ballot initiative. And after a few states were successful through the ballot, then other states tried it, and it came to Missouri as an interesting case because we were a state that, although the legislature had adamantly been opposed to expansion for many years, the voters had done things like pass medical marijuana, recreational marijuana, increase in minimum wage, many things that, seemed to suggest that they were interested in sort of more progressive type issues. So the advocates thought, well, Missouri might go for Medicaid expansion, and they did by a vote of 53 to 47 by about a 82,000 margin. And so then we were off on to the races, and basically what Medicaid expansion means is that the bottom graph shows what our Medicaid eligibility levels look like prior to expansion. We, in almost every state in the country, children are eligible up to 300% of poverty, which you can see in 2021. I didn't update this. I should have updated it later. But roughly $13,000 for an individual, $22,000 for a family of three. And most states in the country, pregnant women are eligible for a few months prior to pregnancy and after pregnancy, up to 200% of poverty. But in states like Missouri, the people who are not eligible for Medicaid were childless adults, say single males, single females, and they were not eligible at all. And custodial parents in Missouri were eligible only to 20% of poverty, which is one of the lowest in the country. So what the expansion does is make everybody eligible up to 138% of poverty, as the top bullets say. Also notable is the federal government generally pays what's called the matching rate for the state dollars. In Missouri, the federal government pays 65% of the cost of Medicaid, and the state pays 35%, roughly. Not quite that, but it's roughly those numbers. Under expansion, for those who are expansion eligible, federal government would pay 90%, 90 out of 100%, and the state would only pay 10%. So there's a considerable incentive to cover somebody on Medicaid expansion, because you can, instead of having to pay 35% of the costs, the state only has to pay 10%, so they save 25% of the costs. Here's some of the numbers from a recent report from the Missouri Foundation for Health. You can see what the actual numbers are. I knew I put this in here. I updated, I didn't do it on the previous slide, but the current poverty rate is about 19,000 for 138% of poverty, and for three people it would be about 32,000. So those are the kind of eligibility levels we're talking about. So what happened after we expanded Medicaid? Basically in the 2021 legislative session, again, the state had to come up with 10% of the costs. The state had done the first thing that the ballot initiative asked for, which was to file what's called a state plan amendment, which is basically to tell the federal government how they were going to expand Medicaid. So that was filed on time in March, but the next thing the legislature had to do was basically budget the 10% of the dollars, but the legislature refused to put that money forward. So the governor withdrew the state plan amendment, and that led to a lawsuit by the advocates. All of us knew there would be a lawsuit one way or another. And even if the state had agreed to expand Medicaid, the other side probably would have sued. So this went to the courts. The lower court actually said the amendment was unconstitutional. One thing I didn't say, and I probably should have, Missouri took an interesting route, and one that no other state has done so far, was they put the Medicaid expansion in the Constitution. So most other states actually said you have to expand Medicaid, but it's done through the legislature. They don't touch the Constitution. In Missouri, they were worried that the legislature might mess around with it, so they they put it literally in the Constitution, and to protect the Medicaid expansion. So it's actually codified in the Constitution. So the lower court said you can't do that, and that is unconstitutional for some complicated reasons that I could maybe explain, but so that was immediately appealed to the Supreme Court. Both sides agreed they knew this would go to the Missouri Supreme Court eventually, so they just bypassed the appeals court. And then on July 22nd, 2021, the expansion was ruled unanimously that it must proceed. The Supreme Court said yes. So the state started accepting applications in July of 2022, and opened in October July of 2021. I got that wrong. And started enrolling individuals in 2021. So the current status, just to update you, is we have almost 300,000 people enrolled in Medicaid. And when I go around the state, people are surprised when they hear that number. They sort of, you'd be surprised how many times people say, hey, has expansion started yet? But yes, expansion started. We have almost 300,000 people enrolled in expansion. So here's what, and this is a complicated diagram, but this is the weekly enrollment in Medicaid expansion of what's called the adult expansion group. And it's a pretty steady growth in that number. It started slowly, and I'll talk about some of this in a few minutes. So we started, as I mentioned, they opened up the expansion in October of 2021. And by the end of 2021, we still only had about 50,000 people in the expansion group. And then by April, it was about 150,000, but now we're at almost 300,000. The governor had projected at the end of the year that we would be at 274,000. We almost hit that number almost exactly by the end of October of 2022. So, just a few, I want to go back a little bit to make the argument about the politics and the process in Missouri, and sort of make an argument to you that Missouri is an interesting case, and it's probably a unique case in the country, and being 39 states, as I mentioned, have expanded Medicaid. Now 40 with South Dakota, but I think Missouri in a lot of ways is probably one of the most unique in the whole country, and the path we take in a long and winding road, as I mentioned. And here's why, a few arguments I'll make. In 2005, Governor Blunt enacted significant Medicaid changes that led to about 10% of the people losing Medicaid coverage and about 10% of the dollars being cut from Medicaid. In 2008, then, when Governor Nixon was elected and President Obama was elected, Governor Nixon ran on a platform to reverse those Medicaid cuts. He also ran on a platform to expand Medicaid, much like Obamacare called for. He was never able to get that through the legislature. As I say, it took, another 10 years or so for that to happen. So we were pretty intransigent, like about a dozen other states. The Affordable Care Act passed in 2010, requiring states to expand Medicaid, but then the Supreme Court made it so that states could make that voluntary, which meant that states like Missouri could say, we're not going to do that. One of the things I think that, and so in 2014, about 25 states expanded Medicaid immediately, mostly so-called blue states. By 2016, 32 states had expanded Medicaid, but then it got stuck there. As I said, about 7 more states started expanding Medicaid along with Missouri in 2021. And as I mentioned, Governor Nixon tried to propose expansion of Medicaid every year while he was in office, but was turned back by the legislature. One of the things that makes Missouri unique, I think, and I don't know of another state that has done this, is we voted statewide twice on a statewide referendum against Obamacare. So think about that. We voted statewide twice against Obamacare, provisions of Obamacare, but yet we voted to expand Medicaid. It's kind of perplexing and paradoxical in a lot of ways. And so in 2010, we voted against the individual mandate in Obamacare via a vote of 71 to 29%. And in 2012, the state voted to prohibit a state-based exchange, actually made it a crime if the state created a state-based exchange, and that passed 61 to 39%. But yet in 2020, we passed Medicaid expansion. That's kind of perplexing, you know, so we got, I don't know of any other state that's like this. So as I said, in 2020, we passed Medicaid expansion, and I already talked about what it required, the state plan amendment, and enrollment began in 2021. Here's what the vote looked like in Medicaid, county by county. Many people notice this is actually literally a snapshot from the St. Louis Post-Dispatch, the county by county vote, and many people notice that it looks very red except for the counties that are blue. And they sort of notice like, oh, you know, it's like mostly red that voted against expansion and blue that voted for it. But yet the state voted 53 to 47. So most of the votes came from about 7 counties that are urban counties. And that garnered a lot of discussion. I did a breakdown of the votes on expansion, and one of the things you can see here is it is true that in the urban areas, the vote was particularly pro-expansion, 63 to 36, and in the rural areas was the other way around, 66 to 33. However, it is true that 21% of rural people voted for expansion, and almost 142,000 people in rural areas voted for expansion. So it's not, it's a little bit misleading to look at that first diagram and say, well, everybody in rural areas didn't want expansion. So, I think I'm gonna, this is a busy diagram here to basically say that when the state decided to work on its budget for expansion, initially the governor said, well, I wasn't in favor of it, but I will pay for it. Just a few round numbers, the expansion costs about $2 billion. The state number for the cost of that is roughly about 130 million, if you don't count the savings that comes from that. Importantly, along the way, when President Biden got into office, the Congress passed the American Rescue Plan and encouraged states to expand Medicaid. And they said, if you expand Medicaid, we will pay for an increased matching fund for you. And what that meant for Missouri was roughly about $1 billion comes to the state to expand Medicaid. And even though the American Rescue Plan passed after we had already decided to expand Medicaid, we still got the $1 billion. So all of this money that we might have had to pay for expansion, we have not had to pay for it because we, the State House Budget Committee created a Medicaid expansion fund, and they put that roughly $1 billion, it was more like 900 million when it was all done. And they put that $900 million in that fund, and we're still drawing from that fund to pay for the state costs. And it'll probably be several years before we exhaust that fund. So that's important to note. And I already covered some of this timeline, and I'll skip this. So here's a little bit of the current enrollment in Medicaid, and this is pretty much the current snapshot. So this is the total enrollment in Missouri. And one of the things you'll notice about the total enrollment in Missouri Medicaid is we started at about 1 million people. The high point in Missouri Medicaid was in 2017. And then enrollments dropped considerably by about 100,000 until the pandemic hit, and that's that green line on the graph. Since the pandemic hit, about 500,000 people have been added to Medicaid. This is a national phenomenon. Medicaid has seen a very big growth in enrollment during the pandemic. And the reason this is happening is during the public health emergency, which was declared by first President Trump and then President Biden's. It's still in place. If a person gets on Medicaid, they cannot be removed from the program. Generally, before the pandemic, the state was allowed to what's called recertify a person. And if the state could check and make sure the person was still eligible for Medicaid and could remove them from the program. And that's why you see the numbers dropping before 2020. But now when a person's been put on the program, they're not allowed to remove them. Well, most of this increase, I can tell you, over time, other than the most recent part of the expansion, has been pregnant women, uninsured women, and I will tell you, it's mostly children. 60% of them is children have been put on the program. So of this 500,000 increase in people on Medicaid, almost all of them, 60% of them are children. So a lot of people are a lot of people have been spending, that think about Medicaid, have been spending time wondering what's going to happen when this public health emergency ends, which Congress passed a bill at the end of the year, which requires the public health emergency to be decoupled from Medicaid, and the Medicaid public health emergency to end in April. So once April ends, once we hit April, the states are allowed to disenroll people on Medicaid who no longer are allowed, no longer qualify for the program. Maybe they moved out of the state, maybe they their incomes are too high, something like that. So there are various estimates of how many people may lose Medicaid coverage, maybe 5 to 15 million. Missouri is at the top of the list of the numbers of people that we may lose in the Medicaid program. So there's been a considerable amount of worry about this. I will point out to you, if you're interested, we have a dashboard that we have created as part of this grant that tracks the enrollment and what's going on in the Medicaid expansion. The link's here, and I'll keep the link up later when we get into the question period, so you can look at it if you want, or it could be dropped. I'll drop it into the chat so you can look at it. The dashboard allows you to look at enrollment in who's in the managed care plans, enrollment by region, and applications, and so on. A few things I want to point out. I already showed you this enrollment graph. Here's something that really has captured a lot of attention. It's a little bit busy, but a few things I'll point out to you is since the expansion started, there have been over 333,000 people that have applied for Medicaid from August 2021 to November 2022. So that's pretty robust. The graph on the left shows the number of people that have applied, the blue bars, and the number of people that have applied, but there was a very significant increase in the number of pending applications that occurred early in 2022 and into the summer. At one point, it hit over 72,000 people were waiting for their applications to be processed. The graph on the left-hand side tells you that it used to take about 9 to 10 days to process an application. That grew to more than 100 days at one point. And I can tell you the law says they were supposed to process these applications in under 30 days. And so there was a lot of people pressuring the state to say, what are you going to do about this? Why is it taking you so long? Process applications. The state basically, literally at one point said it was a perfect storm. They said that they didn't have enough employees. They weren't paying their employees enough, which is true. We have one of the lowest paid staffs in the United States. And then they also said with COVID, people are getting sick. And when they would come into the office after the governor said, you can't work from home anymore, you got to come into the office, a lot of them got sick and had to go home again. So that contributed to the slowness in processing applications. Eventually, the federal government got involved and pressured the state to sort of say, how are you going to solve this? And you can see that that happened in the summer. And the state was forced to agree to what was called a mitigation plan. And they said, and they were promised by the early fall that they would resolve this problem. And to the good news and to the state's credit, they have resolved the problem. The number of pending applications has dropped almost to 0. And the number of days to process the applications dropped to 8. So that's good. So that's one of the reasons why we have processed so many applications and why we're up to 300,000 people on Medicaid. So I'm going to skip some of these slides and I'll go back and answer them if people are interested. In terms of what impact Medicaid expansion is having, I'll tell you that our center did some preliminary work during the implementation period to think about this. And we looked at, and you can see we put out basically 5 different briefs to look at various aspects of this. We looked at what was going to happen to enrollment, to the demographic characteristics, to the geography, where the people would be located who enrolled for Medicaid, what their health status would be, and would they have, does the state have capacity to take care of people? There's workforce shortages that many people have been worried about. And would the managed care plans have the capacity, the network adequacy question? So we have several briefs, which I won't have time to dive into all those. I can tell you basically, it's really kind of too early to tell on a lot of this. One of the things that we're doing is we have a database that has all the hospital records for the entire state of Missouri going back to 2017 and for the first 6 months of the expansion. And I don't have this on a graph, I'll just say it verbally to you, that in the first 6 months, in a period of the public health emergency and the first 6 months of expansion, we've seen a 7 percentage point increase in the hospital payment that's come on from Medicaid, and a 7 percentage point drop in uninsured, uncompensated care, sort of mirroring those effects, which is exactly kind of what you would expect. So it's pretty preliminary, and we haven't been able to dive much deeper than that to look at how that varies by geography, how that varies by type of individual or type by disease category and such. We're going to be doing that over the next few months, but that's relatively expected, I would think. But on the other hand, will be definitely worth watching. So there's I'm going to wrap up here in a couple of minutes, and then we'll see if there's more questions that I can ask, and I'm sure I've gone through a lot. So I can go back and cover other things. I think the kind of questions that people are asking about expansion are in, I'll list a few categories. Do we have, are we doing enough to enroll everybody who is eligible for Medicaid? Are we doing enough outreach? I think there's some questions about that. Frankly, we've been monitoring the enrollment. We're probably hitting our targets in St. Louis and in the urban areas, but probably not in the rural areas. That's what it looks like preliminarily. And we're looking at this from an equity aspect. And I think that's related to the urban rural numbers that I just cited. Do we have enough provider capacity? And we basically, the problem is we started with provider capacity shortage, and then now you're laying on demand of 300,000 people getting Medicaid coverage. Now, I'll caution you to say that that may sound a lot worse than it is, because we have learned that a really good proportion of that 300,000, maybe even half those people were already on Medicaid, and they got shifted over from one type of Medicaid coverage to another because they went on during the public health emergency through the uninsured women's program, through the pregnant women program, and so on. So it's not like they were getting no health services at all. But there may be some increase in demand, but I think it'll be a while before we know whether that's the case or not. As I mentioned, there'll be some significant rural and urban health issues. Just in general, sort of outside the Medicaid question, I will tell you that hospitals are stressed around the whole country. And there's a lot of evidence to suggest that's the case. It's not because of expansion. In fact, expansion's helping relieve some of that stress. The stress is probably happening because of a combination of, high wage increases for certain workers like nurses and other folks, high and some increases in health prices, and then not ability to raise prices for Medicare in particular. So the biggest problem that hospitals are facing is on the Medicare side, not necessarily on the Medicaid side. So what I'm hearing and what you read in the press is, the articles about this is that the problem that hospitals are facing is rising costs, but their ability to raise prices, particularly in Medicaid, is hard. I mean, Medicare is hard because of Medicare policies at the national level. We're going to want to watch what happens with managed care, because Missouri is somewhat unusual in this regard, that all the enrollees in those categories of aged, blind, and disabled are not in managed care. That means that everybody who is not in those categories is in managed care, which means that everybody who's going into the expansion population, all 300,000 of these people are going into managed care contracts. There are 3 contracts in Missouri, and those are an RFP went out right about the time of expansion. The same 3 plans got those plans renewed, and we're going to want to watch how that's going as well. We don't really have enough evidence to monitor that yet. And what is this doing to the budget? As I mentioned, right now it's neutral. It's not added any cost to the state's budget, in part mostly because federal government gave us $1 billion to pay for the Medicaid expansion. So if there was any state costs associated with that, that is being covered by that federal money from American Rescue Plan. But there's also been some savings that have been the state's seen because people have moved over from one part of Medicaid to another. And I'll skip over the economic effects until we know. Here's a little bit about the impact of Medicaid expansion project that we're looking at here. We're basically doing a quantitative and qualitative look at expansion. And we're looking at the impact on equity. And because the foundation asked us to do that, there are 3 grants that the Missouri Foundation for Health put out, and Washington University got one, St. Louis University got one, the University of Missouri in Columbia got the other one. And we're all looking at various aspects of equity associated with expansion. We are in particular looking at underserved rural and urban communities. So we're going to be looking at what's happening to hospitals in rural and urban areas and people living in those areas. The Missouri University of Missouri people are looking more at the provider capacity issues, and the people in St. Louis University are looking more at food security and insecurity. So I will conclude there, and then I'll see. I'm sure there's some questions. I went through a lot of material quickly, but just in general, I'll say that Medicaid expansion was a hard-fought victory for the advocates, loss for those who didn't want it, obviously. As I mentioned, the Obamacare passed in 2010. It took until 10 years later for the ballot initiative to pass. Challenges remain. Some of them we've gotten through in the first year. The implementation issues, some logistical challenges. We have some preliminary evidence to suggest that this is leading to some drop in uncompensated care costs. And what I tell my colleagues who are doing research, this is a great natural experiment to look at for research purposes. And I'll stop and see if there's any questions. And actually what I'll do is put up additional links in case anybody wants to look. I haven't been monitoring the questions, but maybe you're going to tell me what they are, Sarah.
Yeah, absolutely. And thank you so much, Tim. It's really insightful, and there's some good things, but also a long way to go. And so a lot of the questions kind of stemming from that. Let me see if I can go up to this first one. So I did have one question, if you have data as to what the enrollment numbers are like specifically in rural Missouri, given that hospitals have been closing in rural Missouri. Are there stats on funding that the expansion has been brought to the small towns? What do you know about that?
So some of this you can find by looking at our dashboard, because we show the data, the enrollment numbers by county. So that's the good news. So if you go to this dashboard, the first link that's on your screen right now, and maybe I'll try to see if I can put it in the chat, so you could go to that link. But I think what I will say just in general is the enrollment growth has been more robust in urban areas than rural. And part I say that we did some projections of what the enrollment would look like statewide and then county by county. And St. Louis area, and to some extent, I think Kansas City and Columbia and Springfield hit their targets eventually, probably a few months ago. But in some parts of the, or not targets, but hit the projection a few months ago, but the rural areas have not hit those targets yet. So, for example, the Missouri Foundation for Health is putting money into, they got $1 million grant from Robert Wood Johnson Foundation to put money into outreach into specific counties in the state. And they're putting a lot of that money into the northeast part of the state, the southern part of the state, like Ozarks in particular. I think they picked about 15 or 20 counties, and they're trying various different approaches to try to expand outreach and enrollment.
Thanks. And so kind of stemming off of that, this next question, it kind of speaks to that gap. Then, what do they do with all of that surplus of funds that are dedicated to Medicaid but aren't being utilized right now?
Well, it's kind of a tricky budget question. The spending doesn't happen unless somebody enrolls, the way to think about it. So, unless a person, enrolls in the program and spends money, then the state has to pay actually the managed care plans, which then pay the providers. So that spending is not triggered until the person enrolls. So, if for a while, as I showed you, we were significantly lower than the enrollment was expected. In most other states, when expansion happened, there was like an almost immediate, about half the enrollment happened in like the first couple months. That didn't happen in Missouri for reasons that I talked about. But that didn't mean that the state had extra money sitting around. It just mean they weren't spending money that they expected to spend. And eventually when people enrolled, they spend the money, but 90% of it comes from the federal government. But even more than that, really 100% comes from the federal government, because the federal government gave us this $1 billion, and they don't really tap that. The state really hasn't even tapped that money yet, to be honest with you. So it's not really affected the state budget at all.
Makes sense.
Well, it's made this, let me step back for a second. It has affected the state budget. The state budget's larger, but it's not affected the bottom line. We haven't had to raise taxes, let me put it that way, on Missourians.
Good news. Great. We had a few questions about provider capacity. One person's wondering, how who leads provider capacity research, and then in that research, what does that data collection look like? What are we kind of capturing when it comes to what provider capacity actually is?
That's a great question. I would say that, so we've done some work in this regard, and if you go to our website, it's on the screen right now. If you go to the Center for Health Economics Policy website, publichealth.worcester.edu centers CHEP, you'll see that we have some interactive maps that look at provider capacity. So we show the number of physicians per capita. We show the number of all sorts of other workforce numbers by nurses, RNs, NPs, and so on. We also show psychiatrists, psychologists, that kind of thing. And so those numbers are there. So that number is drawn from the disconnect, I will say, and that is those are the actual capacity of providers that exist in those areas. It doesn't say they're actually providing care to Medicaid recipients. And it's kind of well known that a pretty good number of providers, physicians and so on, it's a little hard to get a precise number in this, but some providers do not take Medicaid patients. The place at University of Missouri in their health policy center, I would say, is the expert that has the most precise data on this, other than the state, in knowing if you wanted to ask the question of literally how many providers are actually providing care to Medicaid recipients. Mizzou has those numbers, and my understanding is they're being asked to, well, they would really love to put up dashboards, and they're asking the state government to do it, and I think we might see more and more of that as we go along. And the way they actually do this is by basically scraping the claims data and aligning it with the provider data. So you can say that Dr. Birch, it shows up in the claims data as with a claim has providing care, and then we can go link it to another file that shows Dr. Birch's characteristics, and that's how they do it. And they've done that data, but and so I think they're the ones who will be able to answer more precisely what percentage of those providers are actually caring for Medicaid recipients, because that's the real tough question that we don't have a real good handle on necessarily.
Yeah, I think that's helpful. There's another question too. Yeah, just wondering, where are medical providers for the people now that they have this expansion, and do you or are others kind of working toward, recommendations? It sounds like having a dashboard that actually shows like who's providing is kind of, putting the pressure back on to providers to start accepting Medicaid, but other recommendations for trying to increase, provider capacity and access.
Well, yeah, sorry to step over you. I wouldn't say we're putting the pressure on them. What we're doing is we have both a qualitative component and a quantitative component. So one thing I didn't really address because I went by quickly is, and I'm sort of the quantitative guy, I have to admit, so that's my bias. We have a whole qualitative team, which is doing focus groups and interviews in 4 different parts of the state, 2 urban and 2 rural. So we're going to St. Louis and eventually the central part of the state around Columbia. And then we're also going to Northeast Missouri and down near the Boot Heel. And we're actually talking directly to providers. We've talked to providers first. By that, we mean, physicians, FQHCs, safety net providers, and asking them how it's going. We have some, I would say, real preliminary findings on that, but it would be probably shouldn't characterize those findings too much, because most of what we're finding is from the early part of the expansion, and what they were mostly saying is we're finding this difficult to sign people up, and we're not seeing many people sign up. So the answer to the kind of question you were asking is we're probably getting that now as we speak, because it's only been in the last 3 months that we've seen a big increase in enrollment. So eventually, hopefully, you'll get it out of the qualitative piece and eventually out of the quantitative piece, especially from the hospital data that I've talked about.
Yeah, and then so kind of in relation to just the kind of slow going of applications, we had a question, it seems logistically that it's taking longer for seniors to be approved for Medicaid, more barriers and hurdles. Have they noticed any more complaints or concerns about the timeliness of the application process, that sort of thing?
I will say that I think right now the application process is going well. I get on phone calls, probably 3 or 4 phone calls per week, and the state gets on several of those phone calls, and we ask them a lot of questions, and the people on those phone calls are a mix of researchers, foundation people, lawyers, a whole range of people actually doing the enrollment and outreach. And so they ask the states a lot of questions, and to their credit, they are answering our questions and working through the problems. And I feel pretty confident now that it's working pretty well. And I think they're doing the best they can. And and maybe it was because the federal government came in and did this mitigation plan and said, if you didn't do it, we're going to put the hammer down on you. But nevertheless, I think the state's doing the right thing now. The real question we're not the only state that's worried about this right now, is what happens in what's called the unwinding. When the public health emergency unwinds, and like I showed you, we've added 500,000 people to Medicaid during the public health emergency, of which 60% of them are kids. And many people, and what's basically going to happen is they're going to take all 1.5 million people on Medicaid, and they're going to divide that by 12, and every month they're going to ask every one of those people to prove that they're basically still eligible for Medicaid. And last time the state did this, everything kind of went haywire. And there were a lot of problems. That's back when I was chair of the committee. And I'm hopeful that won't happen this time. And we've asked them a lot of questions to make sure they'll do it, in sort of the right way. And we're getting the right answers so far. But that's a lot of applications to process. And the state is understaffed. So, and it requires a lot of thinking that we kind of do at our school, like as social work, public health, social policy folks, to think about things like social determinants of health, cultural competency, like you got to ask these questions in the right way. You got to think about people where English is not their primary language. And a whole bunch of what's their characteristics that they're living in. And you have to be thinking about all those things. And a lot of that is where the problems came in last time. You can't expect a person to get on the phone for an hour who's a low income person that's got a minimum wage job. They'll probably lose their job. So if you got a single mother that's sitting there on the phone that's working in a minimum wage job, and you want to make her wait for an hour at a call center to get her answers to her question about why she got a letter from Medicaid, she'll probably lose her job. And, so you have to be cognizant of that.
Yeah. And those socioeconomic disparities kind of get at another question that we received, which is just, comparatively, how does Missouri look? Rural areas, do we have a more wealthy rural population compared to, across the country? Are just kind of interested in understanding, why the number of rural enrollees is so low, and how does that stack up to what it looks like in other states?
Yeah, it's a really great question. And, I've done rural research most of my career. And I will say, interestingly, our state is not the bottom of the pack. It's not the top. Where, there's some things that have worked in our favor to, I'll start with the positive. I always like to say some things positive, like believe it or not, we were the first state to expand children's health insurance coverage. We were one of the first 2 states to expand children's health insurance coverage to 300% of the poverty line. So we have had a history of some politicians like Kit Bond and others who have been very pro-child. And we've also had a history of having some pretty strong leadership in the Medicaid program, and competent leadership there. So that's worked in our favor. In terms of rural areas, it's certainly true that we have some tough areas with high poverty rates and social determinant problems in rural areas. Say down in the Boot Hill and the lead counties, where we've lost a lot of employment, or up in the northeast part where there's a low number of providers. But we have some parts of rural Missouri, such as a little bit west of Missouri, St. Louis, that are retirement destination, wine country. And so you can't, with a broad brush, say that it's all the same. And there are certainly other states that I think are worse off. We did lose, though, about 12 rural hospitals over a 10-year period, and that's a real concern. And some evidence suggests we have a lot of hospitals teetering on the edge. And that's one reason many people thought that we needed the expansion to help them not go over the edge. And so a lot of us will be watching that over the next few years.
Thanks, Tim. And I think that actually speaks well to this last question that we have is there any initiative to increase Medicaid reimbursement to improve acceptance and capacity?
That's an interesting question. I think the most encouraging sign that I will see that we're seeing the legislature right now is a movement to increase postpartum coverage for women in Medicaid. They were working on that last term, and they almost got it through, but it got into last legislative session was sort of a mess with redistricting and all that. So it got caught up in all sorts of messiness. But my understanding from reading things is they may actually move that through real quickly. And there's federal government has done some things to encourage states to increase postpartum coverage for women. So where we see expansion, it'll probably be there. I'm not certain we'll see much expansion in terms of reimbursement otherwise, but I will tell you, the state is really got its mind looking at rural health. There are people there that are looking at models that might help rural hospitals in particular. You would think that would be the case because, a lot of the legislators are from rural areas. So I think there's some alignment of that in that they're actually trying to think of models, payment models that will help rural hospitals. So I'm mildly encouraged about that. I hope that, that'll probably go a little bit under the radar screen, but I think the governor has proposed something in the budget to help rural hospitals as well. So I'm a little bit hopeful.
Great. Well, we will end on that on being a little bit hopeful.
Yeah.
Thanks so much, Tim, and I'll turn it back to Danny now too.
Yeah, Tim and Sarah, thank you for engaging in this really important conversation in our region and doing it through the open classroom and curriculum showcase. So thank you.